All right. Good morning and welcome to Friday Chalk Talk. Thank you all for joining us for today's discussion on some past and some potential future research on heart failure in palliative medicine. Today, I have the pleasure of introducing Dr. Jim Rudolph. He's a professor of medicine and health services and practice at Brown University and directs the VA Center of Innovation in Long-Term Services and Supports. He is a triple threat clinician in that he's a clinician, a researcher, and an educator. He is an active clinician who works with the interdisciplinary teams to identify at-risk patients, modifying risk, and provide medical care with a focus on function. He's developed clinically innovative methods and programs to improve recovery after hospitalization. And driven by his clinical work, his research uses the health system to develop and implement changes that improve the lives of older people. He has over 130 peer-reviewed scientific publications, and he was the founding president of the American Delirium Society, serves on its board of directors, and is planning the 2023 American Delirium Society Conference in Providence, Rhode Island. Welcome, Jim.
Thanks, Marty, and thanks really for the invitation. I was particularly excited for this because I think we learn a lot by stepping out of our silos. You know, I live in an integrated health system, and that's awesome. The challenge is that I live in my system and you live in your system, and only by collaborating and sharing ideas across the system can we really generate ideas that help both systems move forward. I am committed to palliative care and to geriatrics and advancing the field, and that includes in a couple ways. The first is I want my research to do that. The second way is I want to train palliative physicians and geriatric physicians in both the ways of research and how to use data in their future. And so I'm really excited for this opportunity. I do have some slides to sort of set the stage for what I hope is a fruitful discussion. And I'll just kick in. Ooh, in there. All right. Just a quick disclosure slide. I have grants that are funded by both the VA, NIH, and our local physicians organization. I'm also a VA employee, so everything you hear coming out of my mouth is my words and not the words or policies of the VA or the federal government. So we can have a very robust discussion on palliative care, or Jim can have a very robust discussion on palliative care. Those are Jim's words, not the VA's words. So heart failure, I sort of stumbled into heart failure. I really am a delirium researcher by nature, and heart failure happens to affect the brain as well. So there's good reasons to engage in this arena. There's a couple points that I think are really salient to palliative care in this. And the first part is in that second bullet point. Cardinal manifestations of heart failure are dyspnea and fatigue. Those are right in palliative care wheelhouse in my eyes, because we see them in so many of the patients that we care for. The other part that's really in palliative's wheelhouse is the chronic and progressive nature of heart failure. We're not fixing the heart. I mean, we can put in an LVAD and really try and improve function, but it's an external device that's dependent on the batteries, and people don't live forever. And so the chronic and progressive nature of heart failure means that the course is a little bit longer in heart failure, but that doesn't mean that palliative principles can't be engaged early and often. Marty and I were having a discussion before everyone started. One of the advantages that cardiology has over palliative care or geriatrics is just the huge number of cardiologists. And what those cardiologists do in their idle time is they come up with clinical practice guidelines. They review the literature, they know what evidence is out there, and summarize it so that future cardiologists don't have to go and look at all of that evidence. The great news is that palliative care is increasingly added to the heart failure literature. And so here's some of the key components that I pulled out. I think that if you were to do a more systematic review of palliative care and heart failure, you'd find that increasingly palliative care is being introduced into heart failure earlier and earlier. There's a couple, I pulled a table from one of these studies, And there's two columns here. The first is sort of the strength of the recommendation. And this is based on whether the risks really outweigh the benefits, and that's a level 1 recommendation, or the risks kind of outweigh the benefits as a level 2 recommendation. Now, palliative care is not typically risky within the cardiology realm. Doing heart surgery, that's risky. Engaging someone in a discussion about their goals of care, not as risky. And so they're still willing, the cardiologists are still willing to make really strong recommendations on relatively limited data. And that's what you see, the level of evidence there. It's graded as a C with limited data for a lot of those recommendations. It doesn't mean that they're not recommending it. And I think what we're seeing is that cardiologists are increasingly recommending that. And I suspect it's probably younger cardiologists that will be increasingly recommended it too. So palliative care is increasingly engaged in heart failure. Where this is pertinent to me is that I work in the largest integrated health system in the US. We have medical centers in all 50 states and Puerto Rico and Guam. We have about 7 million lives covered in a network of 170 or 170 medical centers. 150 of those are acute care hospitals. We have 134 nursing homes, 1,200 outpatient clinics, and extensive home-based care programs. Every one of our medical centers has a palliative care team. And in 2008, there were a handful of medical centers with a palliative care team. By 2012, every medical center had a palliative care team. And that's just the power of a little congressional boost to say, you will do this. And lo and behold, they made it happen. It's been great for veterans. It's been great for palliative care as a field. With that growth, there's tremendous variability, right? Naturally, palliative care would probably first align with oncology, because oncology has a much more structured time course for their functional decline and symptoms. However, there's a number of systems that probably have engaged with heart failure along the way. We have, in the VA, we have specialized systems or specialized centers. So when I was in Boston, we had a center of excellence in ALS care. And sure enough, that ALS care included palliative care in that team. In Providence, we're a much smaller center. We actually send all our ALS patients to Boston, so to that center. And so there's a different vibe to our palliative care team here in different centers. So when I say palliative care, understand that there's variability across the system. I work with some cardiologists who have been curating a cohort in heart failure for about a decade. And this is really a tremendous resource when you look at it. There are about 2 million veterans who are included in our cohort. That includes about 700,000 hospitalizations. And because people get hospitalized more than once, it's about 300,000 veterans who have been hospitalized in the VA system. When they're hospitalized in the VA system, we have tremendous data opportunities. So we have, who the veteran is, but we also have what they've been diagnosed with in the past. We have what their labs are, what medications they got. Did palliative care see them? And what happened to them after the hospital stay? We have matched those 300,000 unique veterans to skilled nursing facilities. And from a data side of things, skilled nursing gives us access to the minimum data set, which is a structured assessment that's required by Medicare. It includes about 400 fields, but it also includes standardized measures of function, cognition, delirium, and mood disorders. So we really get a tremendous understanding of at-risk veterans when they leave our health system and go to the hospital. I guarantee you no one's gone from hospital to nursing home because of my data request. We're just doing this all retrospectively, but it really jumpstarts our data components. If a veteran is hospitalized for heart failure, that veteran has about a 25% 1-year mortality. If they're discharged to a SNF after that heart failure hospitalization, there's about a 50% mortality. So this is, as I mentioned, this is a life-limiting illness, and hospitalization for heart failure is a bad prognostic sign. What we've learned along the way, and I really want to emphasize that this is not entirely driven by me. I have access to the data and I have the knowledge to drive this. These studies are driven by young people who come to me and say, I'm really interested in palliative care. How can I make my name in the field, and how can we make the field better? And so our first, all of these are written by trainees of ours, and with my guidance, how's that, and our data. So the first thing we did was a systematic review of what's available in the literature, and lo and behold, there's not a lot, but we do know that when palliative care is engaged with heart failure, those interventions that palliative care does probably reduces readmission. So that's, it's a good, solid base to start with. The next thing we did is we said, hey, one of the unique things of our feature is we have this common electronic medical record. What can we do to identify that group who really needs to see palliative care? And lo and behold, using just data in our electronic medical record, we can identify a group that's really pushing a 60% 1-year mortality. That's right for palliative care. Maybe not perfect for hospice, but really ripe for palliative care to begin those goals of care conversations with that. We did a study looking at, hey, in people who received palliative care and people who didn't receive palliative care, what happens? And not surprising to anyone on this call is that when palliative care is engaged, those patients with heart failure have fewer readmissions, they're less likely to end up on a ventilator or in an ICU, and they're less likely to have a defibrillator implanted. So again, good interventions by palliative care to reduce some of those early stressors and quality of life issues that we talk about so much in palliative care. We had some trainees who were very interested in looking at disparities in care. And so we looked at the entirety of group who had palliative care consults. So everyone had access to palliative care. And then we looked at what happened in those two groups. Now, the first thing that happened is that in our system, Black veterans who are hospitalized with palliative care live much longer than white veterans. And I haven't been able to ever explain this, but it's true. And I'm not the only one who's found this. So Black veterans live much longer. And they're also less likely to engage in hospice, which is a known disparity. And they were more likely to have transitions. So readmissions was the primary one along the way. We couldn't fully separate in this study whether that was a function of them living longer. Dead veterans don't tend to come back to the hospital. So, sorry, that was a palliative joke. So we don't know if it was a phenomena of the length of living that Black veterans tend to live longer and so had more opportunity to have those outcomes or not. The next year, we looked at homeless, and VA has extensive homeless programs and does a really good job of screening for housing stability. And so those veterans who were experiencing homeless, while they were less likely to receive palliative care during the inpatient side, we were able to get them hospice care at about equal rates to stably housed veterans. Which, when you think about palliative care and home-based palliative care and home-based hospice care, that's actually really impressive that we were able to engage these veterans with housing and stability in hospice care. So those are where we've gone in the past. But I mentioned early on, I live in my silo, and we know, with my goals of educating and improving our palliative care field, the best ideas on where we go next really derive from you. I mean, I can come up with ideas, and that's awesome, but my ideas might be targeted towards a much different audience. And so, in the spirit of growing our field, and in the spirit of engaging with palliative care physicians, I think there's a opportunity for discussion here, which could really, really help us and help guide, where we take our future research. Some examples that I was thinking of, one is engaging cardiologists. Again, Marty and I were having this discussion about, hey, some cardiologists like us and some cardiologists don't like us. And I don't know what level of evidence, we could present to a cardiologist to say, yes, I want to engage with palliative care. I think having a cardiologist engage with us is important for a couple of reasons. First is it helps patients, right? It helps recognizing that these are life-limiting diseases, and we want to help alleviate some of that suffering during that life-limiting disease. The second part is it really helps our field. Cardiologists have way more clout than palliative care physicians do, than geriatricians do. And having a cardiologist stand up and say, palliative care is important, is much more powerful than having me or Marty stand up and say, palliative care is important. We're preaching to the choir. They're preaching to half of the choir and half not choir. So the other, another question, so thinking about what evidence would help cardiologists work with us. Second thing I was thinking of is, I have the advantage of a nationwide network. And so thinking about what components of that network are really critical to engaging cardiology as well as promoting palliative care, those are things that I might be able to answer. And then the other is what are the pain points that you're experiencing that might be helpful? The example I have is our local hospice director came to us and said, we're being denied hospice by Medicare, or people are being denied hospice by Medicare because their vital signs are normal. And, I have the data to be able to answer that question. I can look at date of death, and I can look in the 24 hours beforehand, and I can come up with some type of baseline, and we can answer the question, what percentage of the time are vital signs abnormal before someone dies from heart failure? That's entirely in my wheelhouse. So that's the discussion I'd love to have, is just to begin understanding what some of the issues you're experiencing is, and how you think we might help our field grow.
Wonderful. Thank you, Jim. So in the chat, I've asked for people to raise their hands, and I'll be calling on people. So Steve, I'll have you go first.
Great. Okay, just turning on my video here. Thanks, Dr. Randolph, for the presentation. It's a really good topic. So I think I'm the system medical director for the Aurora Palliative Program, and I have perspective about what both our flagship hospital as well as what our community hospitals want and are looking for. And overall, there's a lot of excitement and positive. People view palliative care positively, but they're also expecting palliative care to fix everything. So I think what I struggle with as we're talking about growth and where to do new strategy is similar to what you hear in the cancer literature. So what is it in the syringe? What are we doing as palliative care that's improving outcomes? And for the heart failure population, where a lot of the symptom management is actually being managed by cardiology, where does primary palliative care end, and where should specialty palliative care begin? And is palliative care clinic really the best place to put palliative care, or should it be community and home-based palliative care interventions? So your thoughts on that?
And remember, my thoughts are, how do we measure that, right? There's a risk in, I will say, there's a risk in dissecting the syringe too much. And the example I'll give of that is, I spent 2 years building a delirium prevention program at our hospital. And I could show length of stay reductions, I could show readmission reductions, and it was a multi-component intervention. And at the end of it, the chief of medicine, professor at Harvard, stood up and said, "This is great. We're going to buy a box of earplugs for every ward on the campus." And not my intended, not my intended response. I think that it's all too often easy to reduce this to try and say, what's the one thing? And we're just going to focus on that one thing. And we full well know that there's heterogeneity in all of this. And so, thinking about that line between primary palliative care and secondary palliative care, I'm thinking about, are there identifying events that are just so dramatic that we really have to pay attention? And I can say, we can all say there's, the first hospitalization for heart failure, patients may not have known that, but by the second hospitalization, that's a really bad prognostic sign. And maybe that's where we have to say, okay, something's going on here, and it's not, and remember, in heart failure, there's a lot of steps required to stay out of the hospital. Cardiologists are convinced that the medications are appropriate and right and can keep you out of the hospital. And they're absolutely right. I mean, the pharmacotherapy, if followed correctly, is great. What we forget about, or what cardiologists forget about, is getting access to those medications is it requires an entire social structure or functional level that we don't always think about. Eating the right food really matters. Oh wait, if we're talking cardiac disease, it means we have to screen for cognitive impairment, because the two go hand in hand. And so there's a whole bunch of things that are actually involved in taking those medications to keep people out of the hospital, that cardiology hasn't always been willing to engage in. I think they're increasingly understanding that some of those social supports and structures matter tremendously.
Wonderful. Rose, can you go next?
Hi. So I am one of the nurse practitioners that works in the advanced heart failure clinic at St. Luke's in Aurora's health system. Actually, I'd second what you had just said about, a large amount of what we do in the clinic is talking about diet, access to resources, disease trajectory, how can we get you IV Lasix at home? So while those meds are dealt with by the cardiologists, we partner with them in those ways, just like you stated. My initial question, though, partially a comment. No, cardiologists are not all created equal. I'm lucky enough to work with advanced heart failure cardiologists, and they have a much better understanding about this disease trajectory, about end of life. They're much more comfortable with it. How do we get those general cardiologists to be more engaged with us? And interestingly, I think the advanced heart failure cardiologists have this same issue, people not getting referred early enough. And so trying to figure out what is it that those general cardiologists need to hear from us.
Yeah.
Is more than those of us who deal strictly in advanced cardiology.
And Marty and I were having this discussion before everyone joined. I think there's a group of cardiologists who really believe that heart failure shouldn't be life limiting, and I mean, at least they're trying to find ways to extend the life. I don't know that they always realize the challenges that people face just engaging in medical care. Providence is a relatively easy commute. I was telling the story earlier. My mother-in-law passed away about a year ago, but she had advanced dementia for about a decade before that. And our biggest struggle was when the doctor wouldn't prescribe something because she wanted to see my mother-in-law. Then we had to do this production of how are we going to get her in the car? How are we going to get her there? Once we get her there, how are we going to get her, through the ginormous medical center into to see the doctor who's going to go, yes, you have a urinary tract infection. And then we have to get her home, which, it takes her out of sorts for the next 2 to 3 days. So those are those patient stories, I think, really have tremendous value in selling the need for engagement in palliative care. I think I'm going to bash my own folk here. I think that academically minded clinicians are very much focused on what's it doing to the dyspnea scale, less than what's it doing to actual dyspnea. And the only way to get at that is to bring in some of those stories. Would be my selling point to you, is that we need stories to say, no, this wasn't too soon. And that really can make the difference. We also need cardiologists to make the case for us, as I brought in, as I stated earlier.
I think
go ahead.
What happens sometimes is those general cardiologists, we don't get to hear those stories because they've painted a rosy picture. So then those stories don't come to the forefront. Mm-hmm. And everyone is kind of operating in this very different realm of like, everything's great. You're going to be okay. Just take your meds.
Yeah.
So thank you.
I'm with you. Yes.
Something that I feel like we see here at St. Luke's that is a struggle, but may also be measurable, is in the world of cardiac cachexia. If I'm not mistaken, I believe, even though we have definitions of cachexia, I don't think that there is a specific cardiac cachexia definition, which would be useful, because I think that would also help us to show cardiology. Hey, here's what I see. I think your patient might be meeting this criteria. Maybe we could talk a little bit about what that might mean for prognosis. And also, it causes so much distress with patients and families as they see somebody not eating. I wonder if there's an opportunity to look in your data set for people trying things like mirtazapine or et cetera, and seeing, did any of these potential interventions actually help or not? Or is this something that really we should mostly be focusing on educating and thinking about the big picture?
Yeah, thanks, Marty. It's again not an area I had thought about going, and my mind is swirling right now, because weight is so closely monitored in that, but it has absolutely nothing to do with cachexia, right?
Sure, there's a big difference between losing the fluid from Lasix and losing your lean muscle mass.
Exactly, and losing the muscle mass that you need to walk up the stairs or breathe. I think there's a great way. Let me kick that with my cardiology colleagues, because I think that's someone's career, really. If you could define a cardiac cachexia, then you could really think about it. And I don't know. I mean, to me, the other thing that overlaps with geriatrics is the frailty syndrome, and it's a perfect example of, you think everything's well, but the reality is they're falling. They can barely get upstairs, and that means they have to move. So,
yeah.
Was there another hand?
Yeah, I saw Lindsay's got her hand up, and then Lindsay, after you go, I'll have Ramona go after you.
Sure thing. Hi, I'm one of the other heart failure palliative care nurse practitioners. My role is actually to be embedded within the clinic of our advanced heart failure team, which I was going to comment kind of to bridge off of what you and Rose had been discussing, less of a pain point for us, but more of an advantage, I think, that we have the ability to be embedded right with this team. And so we work with the same group of people all the time. And I think that's what ultimately has lended to what Rose was saying before, that, a lot of our advanced cardiologists are really more accepting of what we have to say. And I think through the years of doing this, we've kind of come to a point where they've realized how we can help them see, the bigger picture. We get instances where we get patients sometimes from the general cardiology teams who they've been put on an inotrope to try to, tune them up while they're in the hospital. And then we fail to be able to wean it off of them. And they haven't considered all of the implications of being discharging on milrinone if someone has rheumatoid arthritis and they can't make the connections of their lines or, things like that. I feel like our team through the years of working with us has really come around to thinking of those things first and acting once they've considered more of the big picture.
Yeah, it's easy. Marty and I were having this discussion too. We had a lot of discussions, that when we write a study, we put all those methods in there and people, we don't realize that people actually read those and try and replicate the methods, but there's so much more that goes into it. And what I'm taking away from your comment is the strength of that relationship. It's not, you didn't, I'm sure both you and Rose didn't walk in the first day and say, oh, we're the palliative care team and we're here to help you. It took a long time to build those relationships and for each of you to see the perspective of the other people and the side, the strengths of the other side. So I think that that's one of those things that I'm taking away as just, how do we capture that and be able to replicate it, right? We've had similar experiences. I ran a post-op delirium service for a long time, and similar thing, surgeons don't want to believe that their patients have confusion after surgery, and they're wrong. and it took a long time to build those relationships. So that strength of a relationship, I mean, kudos to you for doing it, but it really highlights that first point I made, which was, we need to step out of our silos occasionally and really do activities like this to engage. And if you have any ideas how we can demonstrate the strength of that relationship in data, boy, I'd be all yours.
All right, we are almost at time. Ramona, I see you had a quick point. Do you want to unmute and ask?
Yes, hi, I'm a supervisor with utilization management with Advocate, and we're running into challenges when patients are discharged to subacute rehabs on the milrinone drips, and then we're trying to get the patient set up at home, and they don't have support or they can't manage the pump. It's going off all night, so then they're readmitted in the hospital, and it's very limiting trying to find a facility that would take a patient on milrinone long-term. And so we're just, we kind of get stuck with these patients. And so we're kind of going back and forth. And I just didn't know, like, if there's other treatments or recommendations, or is that something that palliative could kind of manage and work with cardiology to say, maybe this treatment is better for the patient because they can't manage to drip at home and we don't have, long-term care facilities that would take patients on milrinone, because that's lifetime if they're not doing another treatment or something else.
Yep.
So I was just seeing if you had any recommendations for that type of situation.
So Ramona, I'm going to say good palliative care before the milrinone drip starts is really essential in that step. Is that because once it starts, we've walked down a pathway that we can't necessarily come back from, right? It's much easier to intubate someone than it is to extubate them, or much easier to have a discussion about intubating someone beforehand than it is to have a discussion about extubating them. The second part I'll add is long-term care in a post-COVID world, or SNFs in a post-COVID world. We need to really understand the stressors that are going on in those facilities. And they are not hospitals, and the staff that they're currently able to employ, if they can employ anyone and they're not contract staff, is really minimal. And so we cannot think of SNF as mini hospitals or anything like that. In the post-COVID environment, long-term care is suffering. I anticipate we're going to see tremendous amount of closures going on just because of staffing. And so if you think it's bad now, I think it's going to become a lot worse over the next couple of years once sort of the COVID funding for long-term care dries up. These places are not going to accept anyone except, you know, the person with the hip fracture who's going to go home in 21 days afterwards. It's really going to get a lot tighter. So great point. Bringing up those discussions now is really going to be critical to foreseeing the future.
Okay, thank you.
Thank you.
All righty, Jim. We really appreciate your time with us today.
Great. Thanks, everyone. And again, if you have other ideas, shoot me an email. You just look me up. I'm fine. And I'm excited for the cross-fertilization and really thank you for all your work promoting the field. We're really, we need more of us. So thanks, everyone.
Absolutely. Have a wonderful weekend.
You too.
Take care.